Hey there, it is Intentionally Well with Dr. Bennett. Thank you so much for being here. So I'm Dr. Bennett and I have a guest for you. It's one of my colleagues in the community that I lean on heavily for his expertise in the matter. So I have here Dr. Jason Siegel. So Dr. Siegel, I do want you to introduce yourself to the people and tell them kind of what you do, what's your background, what's your credentials maybe, and we can get into a good conversation.
Absolutely. I'm Jason Siegel. I'm a general neurologist. I have a private practice here in Jacksonville called NeuroNow. I did my neurology residency at Mayo Clinic in Florida. I followed that up with a neurocritical care fellowship. And so I'm boarded in neurology, neurocritical care, and then also brain injury medicine. So I see the breadth of general neurology in the community. I see probably most TBI concussions, neurodegenerative things, Alzheimer's, Parkinson's, and then kind of a smattering of other things out there, seizures, lots of headaches, that sort of thing. And yeah, it's been a grab. I've had NeuroNow going for about 2 years now, and yeah, it's been fantastic.
Awesome. So I'm so glad you're here today because it is kind of this topic that we don't talk about until we need to talk about it, right? And I actually want to focus on the dementia and Alzheimer's part about it. We have an aging community with us millennials. We have our parents. Sorry, Daddy. We have our parents, we have our grandparents, and we may be hearing these terms a lot. We don't know what they mean. So could you give us just a general, 10,000-foot view? What's dementia? What's Alzheimer? Is it the same? Oh,
good question. Yeah, and that's usually where the conversation starts with patients. Do I have Alzheimer's or do I have dementia? So yeah, to take a really broad view of it, when somebody comes in with, let's say, memory issues, we try to throw it into 3 different buckets. Is it somebody just feels like they're not as sharp as they used to, but when we put them through some rigorous testing, they test normal, okay? If we put them through the rigorous testing and, we can see whether it be memory, executive function, they're not performing normally, that's a bucket called mild cognitive impairment, which is something many people have heard of but don't quite know what it means. Now, let's say you have a diagnosis of mild cognitive impairment, it doesn't say why. We don't know. There's a lot of reasons why somebody can have that, which I'm happy to get into. But if that progresses and somebody loses their functional independence, can't live by themselves anymore, can't take care of their daily responsibilities anymore, that sort of thing. And for everybody that's different, and that can be a relatively gray line. But once they kind of cross into that, then we start using that really ugly D word, dementia, of which there are different severities. Alzheimer's is the most common form of mild cognitive impairment and dementia. And it's interesting, people say, what is Alzheimer's? Even this year, neurologists around the world are kind of struggling / debating what Alzheimer's should be defined as. Over 100 years ago, when Dr. Alzheimer was looking at the brains of his patients with bad cognitive and memory issues, he saw these little plaques, these amyloid plaques, which a lot of people have heard of, these little tangles inside the nerves of the brain. And for a long time, we had a suspicion that these were inside the brains of people with memory issues when they get older and things. We didn't have a good way of finding it. So for 80 years or more, we kind of diagnosed Alzheimer's based on, were you older? Did you have memory issues? Did you have other cognitive issues? And was there no other good explanation? And so it kind of fell just to Alzheimer's. What's been really exciting over the last few years is that we have been doing a lot better job. We have a better ability to see these amyloid plaques, evidence of these tangles, using PET scans, spinal fluid analysis, and even some blood-based biomarkers very recently. And so now that definition of it's just somebody getting older and losing their memory, the pendulum has swung heavily to the other side to we should only use objectable biomarkers to define it. And that's up for debate as well, how much we really should rely heavily on those.
So you mentioned there's ways to detect the plaques, right? And so that could be more definitive, but still, it still sounds like it's a grab bag, whether it's truly diagnose Alzheimer's, but there's other types of dementia.
That's right. And just because, let's say somebody has a PET scan that shows evidence of amyloid, they might not even be symptomatic. Wow. They may not ever be symptomatic. And so that's where it still gets kind of gray. Like, how heavily do we rely on a cerebrospinal fluid analysis, a PET scan, blood markers, which are pretty good, but still not as good as, again, PET scans and other tests. And how much do we weigh in how somebody's actually doing?
So I think what we really want to know, now that we know how to diagnose it, maybe even know how to recognize it, if we're seeing those cognitive delays in folks, maybe some memory issues, how do we prevent this, or even prevent progression once we start seeing it?
Yeah, that's
what
a great question.
What can we be doing?
So it's been estimated somewhere between 40 and 50% of Alzheimer's can be prevented.
Wow.
Now,
it's huge.
That is a huge percentage.
It's huge.
Half. I mean, let's say half of Alzheimer's can be prevented. Study after study after study, large studies of tens of thousands of people over, many years, decades, show that it's probably no surprise to a lot of people. The right kind of lifestyle optimization can be very, very helpful, can actually be more powerful than somebody's genetics.
Wow.
You can have a high genetic risk of developing Alzheimer's and still not develop it if you follow the right lifestyle optimizations. And we're going to be talking about weight control, blood pressure, cholesterol, blood sugar control, blood pressure, if I didn't already say that.
So I'm actually curious, you mentioned weight first of all. So is it weight or nutrition?
That's a really good question. So with the American Stroke Association, what a lot of these other studies and groups have done is they do look at weight different from nutrition. So for example, they'll test the MIND diet, which is a Mediterranean diet with low sodium. And they look at weight and blood pressure and all the kind of components that seem to run together independently. Yeah. And they do seem to find that independent control of these things is really impactful. Beautiful. Now, other things that a lot of times we don't think about, cognitive activity, making sure you're using your brain, whether that be through brain games, reading, being cognitively active. Socialization is incredibly important. Sleep is incredibly important. Hearing is incredibly important. In fact, people who have hearing loss and cognitive issues, using hearing aids is one of the few things we can do that actually can make people better, perform better, think better using hearing aids. So we often get kind of, I think, inundated with the vascular stuff, the blood pressure and cholesterol, but there's a whole lot of other things that we have to be looking for too. And when somebody comes in to my clinic with memory or cognitive issues, or bring in a parent with these issues, I try to look at all of the risk factors and not just say, must be Alzheimer's.
Absolutely. And I want to add in, as a primary care doctor, a lot of times I'm seeing these patients first, right? Yeah. That first inclination of like, something's going on. I'm forgetting this. I can't remember where I put my keys most of the time. I get in my car. Hopefully this doesn't happen. I'm getting in my car. I can't remember where I'm going. That's usually kind of late in the game there. But just can't remember, or that brain fog initially. And so from your standpoint, just as a learning for me, I should be definitely checking these other things, like, hey, how well are you hearing?
Yes.
That's a very good one. Blood pressure, I tell my patients all the time, is our silent killer. Now I'm finding out it's our silent brain killer.
That's
for
a good way of
multiple
putting
reasons.
it. Yeah, I like that.
Right? Sleep. People always forget how important sleep is. They think they can run off of 4 and 5 hours, that they've been more effective if they're awake for more time during the day. So I really think that was an important nugget there.
We've both been through medical school and residency. We both have tested that theory. How much can we get done? Yeah, right. We need sleep. We need sleep. We need sleep. We need consistent sleep. We need high quality sleep. We need, what studies are showing is a consistent amount of sleep every night. So people who get 2 hours one night try to make it up with 12 hours the next night. That's no good either. It needs to be the same kind of pattern of sleep every night. It's probably very helpful. How
can we tell we're getting good quality of sleep?
Yeah, so, what I do is I ask a lot of questions. There's a number of surveys out there that, can screen for things like sleep apnea. They can try to determine, are you more sleepy during the daytime than you should be? I mean, do you fall asleep in a conversation easy? Do you fall asleep just sitting at lunch? I do a lot of sleep studies. Sleep apnea, I mean, probably a third or more of adults in America, they think have sleep apnea.
Yeah.
And it doesn't always have to be accompanied by snoring. That's kind of a misconception, but that's definitely could be a sign. But having that obstruction, having low levels of oxygen when you sleep puts a ton of stress on your heart, your lungs, and then certainly your brain.
Absolutely.
Yeah.
Absolutely. I love that. So we talked about, how we can first recognize it. We talked about some of those ancillary things we should be doing, optimizing our health, optimizing our weight, our medical conditions if we have them, recognizing medical conditions and getting them treated. That's absolutely, some great nuggets for us. So now here I am. Let's set a scenario. I'm here. I'm 38 years old. I may have a grandparent that I'm showing these signs, and I don't know if maybe we're too far. I don't know. Maybe we talked to a neurologist. She's gotten diagnosed with mild cognitive delay. How can I help her as this granddaughter that is very concerned? How can I help? Is there things I can be doing around the house for her? Things I should be checking in on her? Places she should go? I mean, I get this one a lot. Supplements.
Oh, sure.
Everyone's in for a supplement.
Yeah.
That's what the TV tells me I need. The ginseng, whatever thing.
Yeah. So one of the things that I really try to work on in my practice is helping patients know that there's not a neurological disease that I can think of that affects just the patient. Everyone that I can think of affects families, support groups, social structures. And certainly, as you're describing, our older relatives want to stay independent. They don't want to leave the house. They don't want to give up the keys to the car. And so that can be quite challenging in trying to help them without them feeling like they need help, right? A lot of our older relatives are very proud. They don't want that kind of help. And classically, many people, as they develop cognitive issues, don't recognize they have them, which is even more challenging. Really, what I have found is trying to understand the family dynamics, because every family is different,
Absolutely.
Can help guide that, how to help the children, the grandchildren, work with the grandparents. Something that I get a lot is, when is the right time to move them out of the house? And I see people who are very early in their disease move out of the house. I see people who never have to move out of the house. And it really comes down to that individual family and what they're able to do safely. And that's something I harp on a lot is safety. Are they driving their cars up on curbs? That's a safety thing. Are they leaving the stoves on? That's a safety thing. If they are unsafe and they're not going to be able to be in a position at home where they can maintain safety, that is a pretty, in my mind, like line hard line that you really start thinking about putting them in a safer situation.
Absolutely. And I've had these conversations as well, particularly, the hospital care where we get the older grandparent in and there's an event where they burnt their hand, they fell down the stairs, something's happened in their own home, realizing now there's no family that lives, maybe a day away, I don't know. Maybe they have to travel to her. And I've brought up this same type of thing as the provider, only meeting this person, maybe even just for that one day. I'm like, is it safe in your home? Same questions, there's screening questions that I had. But I've then also got to talk to that granddaughter that finally comes, or that daughter that may lives out of town that finally comes, and pose it in a different way. I'm like, hey, how could this person possibly help you in the house? Like, you have young kids. Like, maybe, the interaction with young kids, perk this person up. Like, now we're living in a multi-generational household. Like, how could that possibly impact your family? So I've definitely tried to take it to a kind of a back ways positivity point. Like, this person could add to your family. I know, not looking at it as a burden for the grandparent himself. Like, because of course the independence factor, they don't want to be a burden on the family. Sometimes it's not a burden. Only, maybe generations back, this was the norm.
Yeah, I think that's right.
Only a few generations back, this was a norm where we had a grandparent living in the house with our family, and it has only been a help. They can help with the cooking, they can help watching the kids, and all along still have a positive impact, hopefully for longevity purposes, on that grandparent. So I've definitely had those same conversations, and it's a difficult topic to introduce, especially when you're first meeting a family, first meeting a patient. So having long-lasting relationships with those patients, to work on that slowly as a primary care doctor, trying to introduce those slowly over hopefully a matter of years too. It's something I really focus on with my patients here. So.
Yeah, that's great. To the point about supplements, that is something that definitely comes up a lot. So we know that deficiencies in some vitamins, vitamin B12, vitamin D, thyroid dysregulation, these are definitely things that should be corrected. I haven't been real convinced about overdoing it, taking supermax doses of different supplements does things to slow the progression of something or even prevent, but we certainly got to make sure, again, the vitamin levels are where they should be. There are often debates, well, maybe normal for one person is different than somebody else. And I have those conversations with patients as well. There is some evidence that in people who with high genetic risk for Alzheimer's, that fish oil, omega-3 fish oils, can delay the radiographic progression of disease, so MRIs.
Gotcha.
If you have somebody with high genetic risk and they take a fish oil, their MRI a year or two later might not look as bad as somebody who doesn't. This is still very kind of new. And then there's a question of where do you get the fish oil? There's, and then we can get into conversations about how the supplement, industry is regulated or not regulated.
That's a long conversation.
That's a long conversation that we have, that I'm not an expert in. But that is, those are the key things that I kind of stick on. But and I say, regardless of the cause of the dementia, whether it be Alzheimer's or vascular or Parkinson's, we have to hit these more low-hanging fruits. We got to make sure that the cerebrovascular health is good. We got to make sure the sleep is good. We got to make sure the socialization is good, that the physical activity is good. And then
we didn't actually hit that one before. Physical activity. We talked about weight. We're talking nutrition, but just having a healthy, not even balance, a healthy routine, I guess would be an idea of some type of physical activity. Period. Some people think like, I go to the gym to lose weight. I go to the gym to have a physique. That is not why we go to the gym. We go to the gym to live.
That's good. We go to the gym to live. And I'm sure, as you've seen, so when they do these trials and they look at the lifestyle optimization, 150 minutes of low intensity to moderate intensity exercise. Now, how many patients do you have that have hip problems, knee problems, knee arthritis, a whole list of other reasons why it's difficult to be physically active? And so we have to make some modifications. Physical therapy is something I often refer patients to, but also sometimes a personal trainer, somebody who can at least build a guided program, because as you're saying, they're thinking, well, I spend most of the time on the couch and now I have to go run a marathon.
What to do?
Now, why would I go to the gym? I'm surrounded by all these, grunting guys and stuff. No, but there are ways to build guided exercise regimens that can more easily fit into somebody's life and around the constraints that they might have with physical activity.
All right. So thank you so much. There was a lot of nuggets in this conversation, and I don't want to go too deep in the woods in it, but definitely take those high level points that we can do each and every day to help us through those kind of conditions and hopefully preventing them or slowing them in some way.
And to that point, Alzheimer's and dementia of all sorts, but Alzheimer's, it's not a disease of old age. It's a disease of middle age. The biomarkers that we see accumulate in the brain accumulate decades before somebody gets symptoms. The things that we're doing now as millennials make a huge impact on what's going to happen decades from now.
Absolutely.
And so that's something I also talk to their children about, patients' children about, is what are you doing right now with your lifestyle optimizations that could be affecting your risk of getting these down the road. And that's something I really try to focus on, just even in the community, talking to people, that we got to make, we're in the throes of, professional careers and families and stuff like that, but this is the most important time for us to really be paying attention
our own health.
to our own health and what we're doing.
Yeah, absolutely. And you actually brought up something to me earlier today about some new studies about some of they're not novel now, but the GLP-1 agonists in relation to cognitive delay. So of course, and I'll caveat, this is still early. This medicine is still only a few years in the masses. So tell us what they're finding so far.
Yeah, and this does get into the idea of weight loss, and now it seems like every week a new study comes out with these GLP-1 agonists lowering. I mean, they're approved for diabetes, weight loss. It looks like they can be very helpful with cardiovascular and cerebrovascular and stroke prevention, but also a few studies coming out showing that they can delay the progression of Alzheimer's disease, even in people who are not overweight or have diabetes.
Wow.
And that's kind of exciting. We don't know how or when to use them necessarily with Alzheimer's. There are other brand new infusions, monoclonal antibodies that go after the amyloid, which are FDA approved for treating Alzheimer's. The GLP-1s are not, but it's exciting. It's exciting, and again, it definitely, I think, is more evidence that a lot of neurodegenerative diseases, Alzheimer's, dementia, there's a big metabolic systemic component to it, and it's not just a brain disease.
Absolutely. So thank you so much for
for
giving your expertise on the matter. I know my audience loved it and going to consume it and hopefully take some of those nuggets away. So I do want you to have your time to just introduce yourself to the audience once again. Tell them where they can find you, I guess most importantly, if they're looking for a neurologist.
We're on, so I'll say social media wise, we're on TikTok, we're on YouTube at NeuroNow. We're on Twitter and Facebook. Here in Jacksonville, our office is over on South Point Boulevard near JTB and 95. Our website is yourneuronow.com. If you're interested in the preventative programs we have, again, younger people, maybe your parents have dementia, Alzheimer's, yourbrainshield.com. You can see our program there where we evaluate your risk factors now in order to prevent things coming down the road later.
Awesome. Well, thank you so much.
Thank you.
It's been a pleasure.
Yeah, you too. Thank you.
It's Dr. Jonique Bennett with the firm Direct Primary Care. I am so excited to introduce to you the new Lasting Effects Wellness and Weight Loss Clinic. Do you feel muscle pain, muscle aches, joint aches? Or maybe you're looking to lose 5, 10, or 20 pounds, and some of the most hardest places to lose weight are midsection, our thighs. Maybe you are looking for cellulite reduction. Well, I have just the thing. Lasting Effects Wellness and Weight Loss Clinic is starting off with a new service, red light therapy. This is a therapeutic technology that uses not only red light, but infrared wavelengths of light to stimulate the body to produce more energy. Now, this energy is going to cause cellular growth and regeneration for all of the health and wellness benefits to your body. Red light therapy penetrates even the surface of the skin. This increases collagen and reduces the appearance of cellulite. If you are interested in getting into red light therapy, come and join us and see what your health benefits are for this service here at Lasting Effects Wellness and Weight Loss Clinic.